Right.
Once it is done, let me know, so I'll confirm with my contact that it is started.
Yeah, Bharatji, please go ahead.
Can you check if the live stream has started? It has? And you went go live also?
Yes. Yeah, we're in live.
Okay. All right, thanks. Should we begin, Manohar?
Yeah, we can start, sir.
A very good evening to all my colleague doctors joining into this COVID-19 complications, challenges and solutions webinar. A very warm welcome to all of you wherever you are in the country. It is my pleasure to be moderating this session on behalf of the entire team. A special thanks to Hetero Healthcare for planning this and organizing this. Just as a brief introduction, I myself am a clinical immunologist, allergist, and asthma specialist. I have my own clinic, Dr. Roy Health Solutions Multi-Speciality Clinic in Bandra, West Mumbai. I was in America for about 14 years, had been an associate professor of pediatrics and medicine. Have also been an associate editor on the Annals of Allergy, Asthma, Immunology, the second leading allergy journal in America. I am a fellow of the American Academy of Pediatrics, of the American Academy of Allergy, Asthma, Immunology, and of the American College of Allergy, Asthma, Immunology. Do a lot of other things. And without further ado, let me bring you all to our esteemed panelists for today. For the pulmonary perspective of COVID-19 complications, we have Dr. Urman Dhruv with us from Ahmedabad. For the diabetology perspective, we have Dr. SANJEEV PATHAK from Ahmedabad. For the cardiology perspective, we have Dr. Irfan Khan from Mumbai. And for the psychiatry perspective, we have Dr. Anand Nadkarni from Mumbai. A brief word about Dr. Urman. He is the Director, Department of Internal Medicine and Diabetes at HCG Hospitals, Ahmedabad, a recipient of the Gujarat Ratna Gaurav Award by Government of Gujarat, President-elect of the Research Society of Study of Diabetes Gujarat Chapter, recipient of the Oration Award by Association of Physicians of Gujarat, recipient of Oration Award by Ahmedabad Medical Association, and author of multiple chapters in API Textbook of Medicine and International Textbook of Diabetes. A very warm welcome to Dr. Dhruv. We have Dr. Irfan Khan Hamid with us. He is an MD/DM cardiology from Topiwala Nair Medical College in Mumbai and BYL Nair Charitable Hospital, Mumbai. He's a consultant interventional cardiologist at the Dr. L.H. Hiranandani Hospital, Mumbai. He has actively participated in the pulse polio eradication programs of the Government of India on a yearly basis, has been awarded the third best case presentation at the India ACT conference. He's an active member of MARD, Maharashtra Association of Resident Doctors, a consistent performer, an awarded international associate member of the American College of Cardiology, best interventional case presentation at India ACT conference. A warm welcome to Dr. Khan.
Thank you.
We have Dr. SANJEEV PATHAK. Dr. PATHAK is the founder of Vijay Ratna Diabetes Diagnostic Center and Treatment Center. He's a metabolic physician. His expertise includes managing metabolic disorders. He's also associated as an investigator and consultant with DHL Research Center in Ahmedabad. He's the first diabetologist in India to practice the insulin pump therapy. He's been regularly invited at various national and international diabetes conferences. He's the director of the Juvenile Diabetes Association of Ahmedabad, Joint Secretary of the Gujarat Diabetes Association Ahmedabad, President of the Association of Physicians of Ahmedabad. He has fellowship in diabetology and islet transplant training from Oxford Center in UK. He's been a principal investigator for multiple diabetes mellitus clinical trials. He's done training on GCP course investigator meeting, and he's contributed immensely to the cause of spreading key medical ideas amongst his peers through various research, scientific papers, and publications. Welcome, Dr. PHATAK.
Hello.
And last but not the least, we have Dr. Anand Nadkarni with us, who is a MD postgraduate in psychiatry from Mumbai University. He's been in active psychiatry practice for the last 3 decades. He is one society in many diverse settings. He conducts training programs for top corporate executives. He's a mentor for young artists, athletes, players, singers, parents, teachers, and even elite commando forces. He's contributed to the National Planning Commission as a consultant and is on the board of listed companies as an independent director. He's pioneered the Institute for Psychological Health, known as IPH, a unique NGO. Under the stewardship of Dr. Nadkarni, unique community projects like Jidnyasa, that is adolescent sensitization, Ved, which is vocational education, direction and harmony, are now organized in several cities in Maharashtra. He's also the founder trustee of Muktangan De-Addiction Center in Pune. He's also an avid writer with 17 award-winning books in Marathi, many of them in double-digit editions and also being translated in other languages. So a very warm welcome to Dr. Nadkarni. Today, we are going to be talking about something that we've been hearing about the last 10 months incessantly, and that is coronavirus, which used to be a simple cold, cough, body pain, fever virus through the HKU, NL63, 229E, OC43, typical viruses. Then came SARS-CoV in 2002-3, and then MERS in 2011. And now we have the novel coronavirus 2019. Which is 25 times bigger than SARS, but still significantly more contagious and infectious than SARS. It can be transmitted in the pre-symptomatic and asymptomatic stages, which SARS could not be. It would only transmit from really sick people to others. And it is also extremely stable at various temperatures and humidity outside the human body, making this a very potent foe that we'll be talking about. As we know that its entry through the ACE2 receptors, which are present in almost every single cell in the body. And while we knew that multiple organs can be involved, we also now know that through neuropilin-1 receptors, which are very much involved in pain reflexes, it also has immense access into the nervous system directly, also without the ACE2 receptors, making it a very, very potent problem for all of us. We have about 74 million cases globally, about 1.6 million deaths, and about 42 million recoveries. As we can see, US and India are at the top of the confirmed cases. India tops the recovery, which is fantastic. We also know that the deaths have been the highest in US and Brazil, followed by India and some of the other countries. The primary symptoms of COVID-19, as we recognize, which can appear anywhere from 2 to 14 days after exposure to the virus, so there can be a significant incubation period. In this, cold, cough, headache, body pain, fatigue, sore throat, shortness of breath, difficulty breathing, nausea, vomiting, diarrhea. There are many, many different manifestations. And as we see on this slide, the upper respiratory symptoms with anosmia or loss of taste happen to be something that's very unique to this virus. Myalgia, fatigue, malaise is shared by many viruses, including influenza. We know that GI manifestations can sometimes be the only presenting symptoms in some patients. And then other symptoms, which can include ocular symptoms, cardiovascular symptoms, neurologic symptoms, psychiatric symptoms, cutaneous symptoms, can all often and sometimes throw people off track with what this virus is doing, because these can present even without fever, which is absent in up to 20% people. And clearly we know about the very mildly symptomatic or asymptomatic cases and what that do to our entire diagnostic pathology. Now, what's really fascinating is even in people who have asymptomatic infection or mild infection, they can have consequences or sequelae after the COVID-19 infection, which can show up weeks and even months after the problem. The case definition of a suspect case, I'm not going to really bore you all with this, but if someone has acute onset fever and cough, or more than 3 of fever, cough, general weakness, headache, myalgia, sore throat, coryza, dyspnea, anorexia, nausea, vomiting, diarrhea, altered mental status. So you can imagine that this is not mandatory to have fever and cough. A person can come with other combinations of symptoms and clearly some risk factors, though now we know in community transmission, we may never know the origin of the infection. When we talk about a probable case definition, it is again the same what I mentioned before, but it could also be a suspect with a chest imaging showing findings suggestive of COVID-19, recent onset loss of taste and smell in the absence of any other identified cause such as bad allergies or nasal polyps, and unexplained death in an adult with respiratory distress where they have a contact with a probable or confirmed case or epidemiologically linked case to a cluster with at least one confirmed case. We know that there are a lot of different therapies, and amongst this, one of the earliest in the viral early stage response is favipiravir. We subsequently have remdesivir when we go into the greater symptomatic phases. Use of dexamethasone or any other steroids can be very valuable when used correctly in the right cases, as we shall hear from our experts, and also the use of oxygen. So while we have the initial viral response phase with all the typical changes that are listed here on the slide, we later on have a host inflammatory response that can begin from around day 7 or 8 onwards, from where the real risk of getting into hospitals, getting into ICUs and dying begins. And that remains till around day 14, 15, 18, depending on the host's underlying health conditions, comorbidities, and other problems. When we probe the long-term sequelae, we realized that looking at SARS-CoV and MERS-CoV, impaired diffusion capacity for carbon monoxide, exercise capacity was common in the first 6 months, even in those viruses. We know that even after 6 months, post-traumatic stress disorder, depression, and anxiety had a very high prevalence, 1 in 3 people having it, suggesting that the previous coronaviruses also did this, and SARS-CoV-2 is bound to do more than what its brethren have done. When we look at pulmonary sequelae, we know that diffuse alveolar damage has been seen in postmortem studies. There's also platelet fibrin thrombi indicating coagulopathy, and then there's hemophagocytosis and immune cell depletion. We know that the risk of secondary bacterial pneumonia is a real risk when it comes to viral induced susceptibility, and this is something that makes management in the hospital or in the ICU truly tricky and suggests the importance of doing procalcitonin levels and other follow-up measures, because this is a real risk with multiple reasons why it happens, as is listed here. We also know that long-term lung and bone ramifications of hospital-acquired SARS was a real problem with pulmonary interstitial damage, functional decline in lung capacity, and also ending up in femoral head necrosis due to the steroid pulses that were used to treat the SARS patients. When we look at the extrapulmonary manifestations of COVID-19, we realize that again, it's a long list starting from dermatologic to cardiac to endocrine to gastrointestinal, neurologic, the thromboembolic changes, the hepatic changes, and ultimately the renal changes. Our last webinar, we had focused on renal and neurologic. This webinar will focus on cardiac, on diabetology, and also pulmonary besides psychiatry. And one unique extrapulmonary manifestation in the post-COVID phase nowadays that we are hearing a lot about and need to know about is mucormycosis, which is a very rapidly spreading and especially seen in diabetics infection that can be a problem. The persistence of COVID-19 symptoms, which can be ranging from fatigue, dyspnea, joint pain, chest pain, cough, anosmia, rhinitis, red eyes, loss of smell, which can take, loss of taste, which can take a while to come back, even months, lack of appetite, sore throat. We have all seen and heard patients having this. And interestingly, up to 60 days after discharge from a hospital stay of about 13 days average, 32 patients had 1 to 2 symptoms, 55% had three or more persistent symptoms, none had fever or signs of acute infection, and most importantly, 44% had lower quality of life. So I think we are dealing with a real problem that we'll be discussing today. When we look at the cardiovascular sequelae, 78% people in this study out of Frankfurt had myocardial inflammation. Abnormality in findings were in 78, myocardial inflammation in about 60%, independent of pre-existing cardiac comorbidities and the severity of the acute infection or the time of diagnosis. Reduce left ventricular function, increase left ventricle volumes, and native T1, T2 versus risk match controls was very much seen. There is very limited data on how acute treatment affected these things, but ostensibly recovered cardiac function may still be at risk of cardiomyopathy and cardiac arrhythmias, as has been noted. The neurologic sequelae, we've already spoken about loss of taste and smell, but besides this, Parkinson's, dementia, depression, post-traumatic stress disorders, anxiety, the list is very, very long, and amongst that is psychiatric sequelae, including fear, anxiety, apprehension, uncertainty, loneliness, mass hysteria, absenteeism, burnout, guilt, mental fatigue, brain fog, insomnia, anxiety, depression, manic depressive episodes, agitation, delirium, suicides. The list goes longer than this too. And so now what I would like to do is I would like to go ahead and start with our panelists and share some questions with them, which they can then give us some insights on how they manage. And for this, I'll start with Dr. Dhruv. Dr. Dhruv, because the pulmonary complications are the ones that show up most commonly and most obviously for our patients. My question to you is, what are some of the post-COVID complications that chest physicians and pulmonologists like you have been seeing across the world? Can you share some light on that for our audiences? You're muted, Dr. Dhruv. If you can unmute yourself, please.
Okay. Thank you, Dr. Sitesh. First of all, I'm a physician who is treating COVID patients and not a pulmonologist. But yes, we have got an extensive experience now because we were the first to admit the first corporate patient in Gujarat as a whole. So we have gone through a lot of patients. As far as pulmonary symptoms or manifestations of COVID are concerned, we can divide them into two: long haulers, as we call them, where the symptoms persist for a long time and which is absolutely routine, can persist for 3 to 6 weeks. But what we are going to talk just now is post-COVID complications. So we all know surviving disease was a battle in the initial phase of COVID, but now surviving the disease has become one of the battles in this era of COVID, where once the COVID is over, patient is recovered, still symptoms may later on appear. So in both the ways, pulmonary manifestations are many and bound to be many because this is basically a respiratory virus. But the most important symptoms that may appear later on again are fatigue, cough, breathlessness, fever appearing again, chest pain, and palpitation. These are 6 important symptoms. Although they belong to the category or the jurisprudence of pulmonary area, they have got multi-system presentation. As was rightly told by our chairperson, most of the studies have shown that at least 1 out of these 6 symptoms persist throughout the post-COVID era up to 6 or 12 weeks. But in most of the cases, the symptoms lose the severity. But if they continue to remain severe or if they reappear, one has to be very, very careful, especially in a selected group of patients, like high-risk group of patients, where we can avert, revert, or at least delay the pulmonary complication, especially the dreaded complication of pulmonary fibrosis. So to me, chronic cough, breathlessness, and chest pain would be very important symptoms, especially in a patient who completely was back to normal, started back to his work, and then he starts developing breathlessness on exertion, or he restarts having chronic cough or cough. I would keep him alert and I would be also on my toes. Back to you.
Okay. Thank you, Dr. Dhruv. Dr. Pathak, we all know that SARS-CoV-2 is very capable of causing elevations in blood sugar levels and hyperglycemia. So can you share with us what are the kind of additional issues that a patient may face with their pre-existing diabetes or with new onset diabetes or problems with sugar metabolism as a consequence of COVID? So a little bit during the disease and a little bit in the post-COVID phase, and if you are seeing new onset diabetes more than usual amongst these cases. Kindly unmute yourself, Dr. Pathak.
Yes, absolutely. You're absolutely right that we have been seeing new onset diabetes in this COVID era. The relationship of diabetes and COVID is, bidirectional. COVID itself leading to diabetes due to some cause, or diabetic people being more infected due to COVID. Not only the risk of infection of COVID is more in diabetes, but they are also at more risk of developing the complications. And I'd put it as 3-point maze, not the cardiovascular maze, but the major adverse corona events. So hospitalization, need for ventilation, and death, all three are much higher in diabetic compared to non-diabetic. And this is regardless of whether they were diagnosed diabetes at the time of admission or they were having pre-existing diabetes. So hyperglycemia per se is definitely a risk factor during the COVID as far as, and even after COVID, that is post-COVID. Even in the British study or the Spanish study, the Coronado study also, they have shown that the risk of mortality is highest in diabetic patients, especially if their blood sugar at admission was more than 180. Now, coming on to your question whether COVID can cause diabetes. Yes, COVID itself also can cause diabetes. First, it may unmask the diabetes. As you know, any infection or any stressful condition can unmask the existing hyperglycemia. So that may be one of the cause. But some of the studies have now shown that COVID, due to its effect on the beta cells, because the beta cells also contain the ACE2 inhibitor, ACE2 receptors. So due to that, also some reports are there in Japan, in Italy, in Spain, even in Britain. And what they have concluded, it is not type 1, it is not type 2, it is a different kind of diabetes. They have not yet come out with the nomenclature for that. It may be diabetes due to COVID. That's just my guess. So due to several reasons, infection itself, stress, lack of physical activity, food that we take during the illness and post-illness for fast recovery, all this might be contributing. And of course, needless to say that the drugs, especially steroids, which we use in high dose, obviously contributes to significant degree of hyperglycemia. And you are right in telling that the mucormycosis has become not uncommon in this COVID era because of the high dose steroid therapy leading to severe hyperglycemia. So in one word, I would say that the relationship is bidirectional. COVID leading to worsening of the hyperglycemia or causing new hyperglycemia is extremely common.
Thank you. Dr. Irfan, a question for you now. Dr. Dhruv mentioned that some patients come with breathlessness, chest pain, and palpitations. So we know that the SARS-CoV-2 virus seems to like the cardiac cells and the cardiac myocytes and everything around the heart. So what are some of the different cardiac involvements that you all are seeing both during acute COVID and also post-COVID in your practices?
Thank you, Dr. Sitesh. A very good question. See, basically, I think in your presentation also you had shown there is the pathway through which the COVID virus attacks the human body. And one of the most important pathways to the ACE2 receptors. Now, this expression of ACE2 receptors is maximally located in the pneumocytes, the myocytes, and the endothelial cells. So obviously, the most common second organ or the most commonly involved second organ which I have seen in my daily practice is the myocardium, okay, and the endothelium, obviously. So you have a very varying grade of cardiac manifestations which are seen in these patients who are suffering from COVID. Now, I would like to tell you a very thing which had happened to me in March or April when this patient, when this pandemic was just about to be started. We had a young patient coming to us with an acute inferior wall myocardial infarction. Okay, and when this patient had come to us with an acute inferior wall myocardial infarction, we were very
Dr. Khan,
Yeah,
can
it
you?
got disconnected a bit.
Yeah, you were. We lost you for a minute. Are you back? Hello.
Can you hear me,
Yes.
Dr. Sitesh?
Yeah. Now we.
Hello.
Yeah.
Yeah. Okay. So basically, we had this in the month of March when this pandemic was just about to start. We had a case of acute inferior wall myocardial infarction, a young male coming to us, and we were just very. It was a very unusual presentation for us. A 27-year-old male coming to us with an acute inferior wall myocardial infarction, and we did his angioplasty. And in the angioplasty, the lesions also do not look like very thrombotic kind of a lesion. The patient had multiple lesions in all the three arteries. We did what is called as a primary angioplasty in that infarcted artery and left the rest for medical management. But still, we were not very convinced. And in those initial stages, there was nothing like COVID antigen to be done, and then you had a result within an hour's time or so. So we reluctantly, in a way to say, decided that probably we'll send a COVID RT-PCR. We did not isolate the patient at that point of time because we also did not expect it. And unfortunately, after 2 days, the report came and it was turned out that this young patient, 27-year-old male, he was COVID RT-PCR positive.
Dr. Irfan, it looks like your video is pausing. Are you having some network issues?
Yeah, it's getting disconnected, connected repeatedly.
Okay.
Sorry for that.
Okay. Yeah.
Yeah. So I think that is where I think my discussion was that from where we had started on cardiac complications. I think we had a case of acute inferior wall myocardial infarction in March before Dr. Samin Sharma. I think he is from New York. He had published a similar case in the New York Times about a patients with COVID who are presenting with acute myocardial infarctions. And before that, we had a case here in India of an acute myocardial infarction in our hospital at LH Hiranandani Hospital. And unfortunately, that patient, I operated on that case. And unfortunately, 2 days later on, that patient was detected to be COVID positive. So in that way, we started our journey, and then after that, we started educating people in our accident and emergency department that how to segregate those patients who had come with breathlessness and chest pain, that these patients can be cardiac also, but they might be COVID positive also. So probably you need to separate out those patients. And at that point of time, we started segregating out patients, especially who had come with acute coronary syndrome like symptoms, or patients who are having this borderline kind of symptoms. Coming to your question, Dr. Sitesh, that what are the kind of manifestations which we are seeing? So since the expression of ACE receptors is so ubiquitous throughout the body, and what I've been seeing and what the literature says is that the range of cardiac manifestations can be in the range of 8% to 17%. That is what the literature says. The most common manifestation which I see is troponin I elevation, cardiac involvement with just troponin I elevations. Now, what do you mean by this troponin I elevation, which is a cardiac biomarker, is that you don't see troponin I elevation more, that is 2 to 3 times upper limit of normal as abnormal. If the troponin I elevations, they are more than 5 times the upper limit of normal, they are to be treated as cardiac involvement, because in majority of the COVID patients, basically we are admitting patients only with mild patients, so they are sent home. The moderate to severe patients only, they are getting admitted to the hospital. So in those kind of patients, you see troponin more than 5 times the upper limit of normal, and the patient being asymptomatic cardiac wise. They might be having fever, they might be having cough, they might be having slight breathlessness. Subsequently, you do an echocardiogram or a point of care ultrasound for them, and you see that the echocardiogram is absolutely normal. Second presentation, you have troponin I elevations, you have LV systolic dysfunction in such patients. Means that the heart pumping, which is more than 60% what we see, that is the LV ejection fraction, it drops down to around in the range of 40 to 45% or so. Third thing is the acute coronary syndromes. Now, acute coronary syndromes, what we see here is acute coronary syndrome. So acute coronary syndromes, we have seen ST elevation, myocardial infarctions. I think in the last 10 months or so, we have treated nearly 15 odd cases of ST elevation, nearly 25 to 30 cases of non-ST elevation myocardial infarctions who had subsequently detected to be COVID positive. And you have also seen patients who have ST elevation myocardial infarction, who have non-ST elevation myocardial infarctions, but their coronary angiogram is subsequently found out to be absolutely normal. Okay, so probably it's the microvascular dysfunction which is also playing a part in it. Fourth is, I think, arrhythmias. I think arrhythmias also be the most common which I have seen is atrial fibrillation. Patient just presenting with atrial fibrillation, no past history. Okay, subsequently COVID antigen or COVID RT-PCR, you do it. It is found to be positive. You cardiovert such patients troponin elevations which are not very high, and then they are okay. Fifth, which I think you also described in your slide, is Sakho-Subo cardiomyopathy. But frankly speaking, I have not seen Sakho-Subo cardiomyopathy in my practice. But yes, it has been described. I think Sakho-Subo cardiomyopathy is basically seen in patients, especially why it is called a Sakho-Subo. It's a Japanese word, and it was seen in Japanese females who are under acute stress. And Sakho-Subo is an acute reversible type of cardiomyopathy in which you see systolic dysfunction in specific regions of the ventricle. So basically, I think it's not you can tell it that it is a manifestation of stress rather than as a manifestation of COVID. Here in India, I haven't seen basically in Mumbai also seeing this kind of cardiomyopathy. But yes, these are the varied manifestations. Long-term issue. We had also a case of thromboembolism, but that patient was two cases of venous thromboembolism leading to pulmonary embolism. These patients were COVID RT-PCR negative, but later on follow-up, when we did their COVID antibodies, they were found to be positive. So you can also count those cases. So yes, it's a prothrombotic presentation, it's an inflammatory presentation, it's a hypercoagulable presentation. Okay, so when you have three systems which are involved, obviously the cardiac system and the vascular system is going to be affected. Long-term manifestations we don't know at this point of time because we are just probably in the pandemic. Maybe the patients are coming, maybe on follow-up, maybe we'll be able to see whether how they evolve out.
Okay, thank you very much, Dr. Irfan. That was very detailed and very well organized. My next question is to Dr. Nadkarni. Dr. Nadkarni, Dr. Irfan mentioned that just stress can lead to people's heart going haywire, okay, and even to cardiomyopathy. Fortunately, that's reversible. Can you share with us what are the psychiatric issues, obviously related to some form of stress or the other, that you are seeing during acute or post-COVID phases, which you feel may be related to even circumstances and not necessarily the disease? So if you can shed some light for the audiences on what the psychiatrists are now dealing with when it comes to the COVID phase from the time of lockdowns till now.
Yeah. So thanks, Sitesh, and good evening, everybody who is attending this webinar. Let me put out all the jargon and let me focus on what is happening around us. That is very important for a practicing physician or consultant, because that consultant is going to explain it to the patient and to the family. So what is very important is how we are going to put the mental health information about COVID-19. Again, I am avoiding psychiatry word. I am saying it is going to be a mental health information. And that mental health information has to be a part of the consultant's communication, irrespective of the specialty of that consultant. So let's try to understand the phenomena of COVID from the point of view of mental health. First, very important point is that it posed in front of all of us as a society a biological threat. So number one, COVID is a biological threat. It can take my life. Okay, that's the first dimension. The second dimension is that because of the COVID times, I am going to face a lot of psychosocial challenges. So look at the keywords: COVID, biological threat; COVID times, psychosocial challenges. Okay, 4 words, easy to understand. Then look at the third word that is called as my coping prowess. How I am going to cope up with these threats and challenges. Again, make this point that biological threat and psychosocial challenges. Psychosocial challenges are to be dealt with intellect and cognition, by thinking and by intelligence. Now, what is the basic error of all Homo sapiens, all human beings? The basic error is that we have a habit to elevate all psychosocial challenges as biological threats. Please understand our vulnerability. So we already have that habit. इंटरव्यू में मार खाया, यार तेरा जिंदगी खत्म हो गया. Interview is a psychosocial challenge, but we make it biological. There is a problem in relationship, your zindagi is over. There is a problem with your job, oh God, end of life. So all human beings across the globe already have a habit to elevate psychosocial challenges to biological threat. Okay? And add to this a universal biological threat. Then you understand COVID better. Because with COVID, you have a biological threat and you have a prolonged phase of psychosocial challenges. And with that, you have your coping power. Okay? Now, coping power of an individual who is staying in these circumstances. Correct? Now, he may or may not have attracted COVID. We are now talking about a person who is living in the shade of this reality. He already is burdened. Correct? Now, in that, if he gets positive, I mean, the word positive has never been so negative in the world itself, right? So now when he becomes positive, he has an added trigger that is working on his coping. Okay? So this is how you differentiate the people who are not having COVID infection. They are also in the distress territory. And the person who gets it gets an added trigger. Correct? So that is how you look at the mental health challenge. One way of looking at it. The second way of looking at it is that the biological challenge seems to be coming under control and would come in around 5 to 6 months from now when the vaccination and all the preventive things and everything works. And then we will say that now COVID is a part of our health scenario, but COVID is not in that endemic stage. Correct? Now what will happen is that the biological threat will come down, but the psychosocial challenges are serially getting more complicated. Next 2 years are going to be very challenging in terms of mental health. There is already a pressure on lifestyle, a pressure on your consumer behavior. There are obstacles in your careers if you are a student, obstacles in your business if you are a professional, obstacles in your job performance if you are a salaried person. Add to this the problems that last 8 to 10 months have produced in terms of lifestyle challenges and relationship challenges. And these are going to be a little more tougher in the days to come because we had an uncertainty about the biological outcome. Possibly vaccination will get it under control, but the psychosocial uncertainties are going to be a part and parcel of the global environment for at least next 2 to 3 years. So if you look at the whole thing like this, then possibly we understand the mental health challenges which are within this whole scenario. Sitesh.
Correct. Thank you very much, Dr. Nadkarni. That was very nicely explained, and I completely agree that these are issues that build upon one another and make the complications even worse as we go along. Dr. Dhruv, I would like to come back to you with a question. For a patient who has recovered from either a mild or moderate or severe COVID, whether hospitalized or non-hospitalized, what kind of diagnostic or evaluation protocols or algorithms would you suggest that a practicing physician consultant should follow so that they can pick up post-COVID pulmonary complications in a more timely manner and prevent them from progressing? We well know that somewhere between 3 and 6 weeks, as you rightly said, things may continue, but when they go beyond that, and we don't want people to go beyond that without us recognizing it in time. So what would you suggest to our audience consultants about how should that be approached in these patients?
Yeah, thanks. We are following a BMJ module. It's a very nice article given in BMJ, and I would suggest everybody to look through it also. Apart from taking a proper history, symptom onset, current symptoms, very, very important. What are the current symptoms and duration and its objectivity? So what is the objectivity? Occasionally it happens that patient might have symptoms 1 year back also, 2 years back also. So the objectivity of symptoms have to be discussed with the patients. Vitals, very important. Pulse oximeter, patient has to be explained that it is to be taken on a warm finger, dry finger, and the uppermost reading is to be followed, not the lowermost reading, and the device should not be in a mobile. Most of the people are using mobile device which are very, very less reliable. The device has to be stabilized. Then we ask the patient to go for functional status. What is functional status? That is the exertional desaturation. The patient is, if the patient has attended our clinic, obviously he undergoes a 6-minute walk test or a 400-meter walk followed by 1 minute sitting and standing, as much as he can do. And if there's a fall of 3% of SpO2, it definitely suggests some pulmonary complication getting developed. But if there is no fall of SpO2, you can safely clinically rule out impending pulmonary disability in that patient at that juncture. So this is a very important clinical scenario which may be followed. If the patient has a fall of 3% or if the patient continues to report the breathlessness on exertion or chronic cough or fever or any of the symptoms that have been mentioned, then we ask the patient to undergo obviously complete blood count, CRP, D-dimer, TROP-I. Then the patient also undergoes pro-BNP, LFT and RFT, electrolytes. Very, very important because occasionally patients who are taking ARB or SGLT2 inhibitors have a huge changes in their sodium and potassium level. So this is one place where we ask the patient to undergo electrolytes. And if the patient has fever, procalcitonin. Obviously, CT scan would be of lot of help, especially comparing it with the previous CT scan, whether there is improvement or not, electrocardiogram, and urine routine microbe. Another important thing that has already been talked by Dr. Irfan is 2D echocardiography, and especially the right ventricular pressures on 2D echocardiography. I'll take a minute to tell you what happened to one of our patients. A patient who was admitted in May when we didn't have the facilities of oral anticoagulant or low molecular weight heparin, 65-year-old female, rheumatoid arthritis, recovered from COVID a month back, completely fine, went back, had abdominal pain. The patient underwent the USG abdomen, which she had already undergone a month back. And then there was a huge hepatomegaly, congestive hepatomegaly. The patient underwent CT scan followed by pulmonary angiography, showing multiple pulmonary embolism, small embolism, and infarct. So this was one presentation which you can call as a pulmonary presentation or a cardiac presentation, or a better terminology would be a vascular presentation. Patient simply presenting with a huge right huge congestive hepatomegaly leading to right hypochondrial pain. So 2-deco would be of a tremendous help, especially in finding out the right ventricular morphology and right ventricular events that are undergoing. These are the patients where we start teaching them breathing first. So how do we ask them to breathe? We ask them to sit supported. We teach them to relax, shoulders and chest relax. Remember, these are the patients who require to learn the diaphragmatic breathing. So they should know how to breathe. Of course, this would go into the territory of physiotherapists, but a couple of important clues which I would like to give would be the breathing should be diaphragmatic, breathing should be established again. Therefore, patients should see to it that the belly comes out, shoulders and chest are relaxed. Pursued lip breathing, which is very classical, should be initiated, which means the patient should take breath through the nose and should come out with a resistance in the lips, that is a pouted lips. This would help a lot to this patient. Another way by which we ask them to do the same is to blow the balloons. If the 2D and also you can blow with a straw into the water. These are the things that help them a lot. Again, we screen out 4 important groups of patients, which are those patients who required oxygen or ventilation during their prior admission. Number 2, and very important, because most of the studies now show that the patients who develop pulmonary fibrosis are those who continue to have a low lymphocyte count for a prolonged period, or whose CRP has not come down within 7 to 10 days of the symptom onset. So this is another group we try to find out whether the CRP or D-dimer, especially CRP, which did not come back to the normal levels or which did not show the downward trend within first 10 days, absolute lymphocyte count remaining below 1000 for more than 7 to 10 days. D-dimer obviously took a long time to revert back or did not revert back despite anticoagulants being prescribed in full doses, and whose CT score was very high. HR CT score remained very high during initial presentation, that is on the 5th or 7th day of the presentation, remaining about 16 to 25. During this period, we continue the patient to continue with their non-pharmacological intervention in the form of proper diet, enough of sleep, very, very important, enough of sleep. We ask them to go for pace, plan and prioritize their work. Pacing is to break down the work into the small divisions. Like if he's climbing the stairs, he should climb five steps, then 5 steps, and then 5 steps, and take 5-second break, rather than climbing 15 steps and then take a break of 10 minutes or 5 minutes. So pace, plan and prioritize become very important. Don't hold the breath while doing their activities. These are very, very important things that we explain them. Once we find out on CT or through the blood investigation whether his breathlessness belongs to the cardiac, vascular or purely pulmonary, then we treat them accordingly with the necessary drugs. But this is the protocol that we generally follow in our setup. During this time, he is supposed, or he or she is supposed to meet the physiotherapist and psychiatrist to evaluate the psychological causes of breathlessness. Over to you.
Thank you very much, Dr. Dhruv. Dr. Pathak, in the same way that Dr. Dhruv said that they have certain investigations and tests that they would do in order to find out which of these patients have what might just be post-COVID delay in recovery versus real pathology and disease that requires intervention. In terms of those patients who are at risk of developing diabetes or are developing new onset diabetes, or their existing diabetes is not coming under control, what are some of the things that our consultants can do in order to identify these cases, follow these cases after discharge? When should they be calling them back for further investigations, and when should they seriously look about putting them on more long therapies?
So those patients who were diagnosed to have diabetes at the time of COVID admission or at the time of COVID diagnosis, I think HbA1c at baseline or at admission time or at the diagnosis time is very crucial. If HbA1c is normal or say less than 6.5, it is likely that this patient developed the diabetes due to the COVID infection itself or maybe due to the therapy, especially steroid therapy. But if HbA1c is high, more than 7, 7.5, obviously this is pre-existing diabetes which has been unmasked. So HbA1c at the time of diagnosis of diabetes carries very important message that whether the patient was diabetic prior to COVID or he has developed diabetes just now. It also has very important impact on the outcomes. A study published in Diabetes, Metabolic and Research recently has shown that those with HbA1c more than 9 at the time of diagnosis have significantly higher risk of hospitalization, ICU admission, as well as mortality. And HbA1c of less than 8 is having significantly less risk. In between 8 and 9, the risk is intermittent. So HbA1c is extremely important. In the follow-up, we are talking about the post-COVID phase. Regular monitoring of the blood glucose by the self-monitoring measures, glucometer, or these days even AGP. Some of our colleagues have done regular AGPs. Of course, I'm not the one who has been doing regular AGPs of this patient. But self-monitoring, simple self-monitoring, at least monitoring fasting, post-breakfast, lunch, or dinner, at least a couple of times in a day, is extremely important to diagnose whether they are still having hyperglycemia and how severe is the degree of hyperglycemia. In addition, those who are diagnosed to have diabetes, the standard recommendations for a diabetic patients like getting their microalbumin done, creatinine done, which if not already done in the hospital or at the time of the COVID, have to be also carried upon. So these are the standard set of investigation: the blood glucose, HbA1c, AGP if feasible and appropriate, creatinine, lipid profile little bit later on, because all these patients who are diagnosed to have diabetes, maybe type 2 or maybe new onset type 2, are at risk of cardiovascular disease later on. We know that diabetes is a cardiovascular disease, and COVID itself increases the risk of cardiovascular complications. So a baseline lipid profile later on, after the patient has recovered, I think also carries huge importance.
Thank you very much, Dr. That was very, very clear and succinct with some very clear messages that getting the HbA1c at the time of admission and then also following the blood sugar levels later on after discharge and monitoring the other potential organ involvement that can lead to worsening of the outcomes is all very important. Thank you. Dr. Irfan, your next question that I would like to ask you is, as I've asked Dr. Dhruv and Dr. PHATAK, in terms of the cardiology or the heart, what are some of the red flags that physicians who may be treating patients of COVID-19 in the hospital or outside should be looking into and should be paying attention to, or even checking maybe after discharge at certain time points? So are there certain things that cardiologists or the cardiology societies around the globe or world are now learning after about 10 months or longer in this pandemic that we should be doing for our patients? Dr. Dhruv, as has mentioned, 2D echoes can be very beneficial sometimes. So any suggestions or guidance for our audiences on what kind of evaluations should be done in the post-COVID state, and who would be the people whom these should be done for?
Dr. Sitesh, with your permission, I missed one thing.
Yes.
The urine acetone or serum acetone, because euglycemic ketosis, these days we have been seeing in patients who have continued SGLT2 inhibitors. And those patients who are on steroids, if they have severe hyperglycemia, this has helped us in getting the early diagnosis of diabetic ketoacidosis also. So these two investigations are also as a part of routine investigations. And one more important thing, you already mentioned that mucormycosis is now an emerging complication post-COVID in diabetic patients. We should also be looking at the face of the patient at least. Any blackening around nose, around palate, around eyes, it should be taken very seriously, and patient should be investigated for mucormycosis. That's what I wanted to add. Over to you again.
Perfect. Dr. Irfan, coming back to you, cardiac follow-up of these patients post-COVID, so have the complications early.
Yeah, see, basically, when this pandemic started, European Society of Cardiology and the American College of Cardiology and various other groups initially were not very aware about the spectrum of the illnesses associated with COVID-19 infection. So initially, the investigation which they advised did not include troponin I or as an initial test to be done in all patients who were admitted with COVID-19. Okay. Now, over the period of time, as the pandemic evolved and we started seeing more cardiac patients with cardiovascular diseases, it became more and more clearer that all patients who are admitted, and basically in India, we treat mild patients on an OPD basis, and moderate or severely ill patients or patients who have cardiovascular risk factor, we admit them. And over a period of time, it was seen that it is mandatory to do a cardiac biomarker for all the patients who are admitted to the hospital, especially in intensive care unit. Okay. And especially I'm talking about all those patients who are compromised respiratory wise also. Okay. Why? Because there was a study which was done and it showed that if you have troponin I elevations in all the patients, but serially if you monitor these patients, okay, all have troponin I elevation till the day 4 of their admissions, all patients. And after day 4, usually if you have recovery, then from day 4, the troponin I levels, the cardiac biomarker levels start falling. And if you have if you are a non-survivor or you have a prolonged course, you have to be intubated, put on ventilatory support, their troponin I levels started increasing even till day 22. So then probably then troponin I was included in our practice also. Now, in addition to troponin I think I had already told you, if you have a troponin I elevation which is 2 to 3 times the upper limit of normal, which is basically seen due to stress, due to the cytokine surge, the catecholamine surge. Okay, you can see these guys. So these probably are not red flags. If you have a troponin I elevation which is 5 times the upper limit of normal, then you need to have a point of care ultrasound. What do you mean by point of care ultrasound is that because a 2D echo involves a close contact between the technician or the doctor and the patient. So we want very focused images to be taken in such patients when they are getting admitted, especially when they have a troponin I elevations which are abnormal. Okay, since we don't want the spread of infection, and we want the pulmonary artery pressures, we want the LV ejection fraction, we want to see and look there is any mitral regurgitation or an aortic regurgitation in such patients. We want to look at the pulmonary arteries. Okay, and we want to see if the patient has got any pre-existing disease. Has he developed pre-existing LV dysfunction, whether it has deteriorated or whether it has remained the same. Other than that, we don't want any kind of measurements in such patients. Only those patients who have persistent troponin I elevations we need to do a detailed 2D echo for them. Otherwise, a point of care ultrasound is sufficient for them. Now, what are those patients whom you need to red flag? Suppose you've not done a troponin I, you've not done a 2D echo, but still there are some patients which we need to be aware of it. So probably I would like to see that patients who are having high D dimer levels. Now, even anticoagulation according to ESC for patients who had low risk of thromboembolism is based on the D dimer levels. Okay. So patients who are obviously at high risk of thromboembolism, that is patients who have got high respiratory rate, patients who are morbidly obese, patients who are desaturated, patients who have increased ferritin, there will be obviously prescribed with anticoagulants while they are there in the hospital, probably for 2 weeks later on. But for patients who are low risk of thromboembolism, D dimer and their levels are very important, because D dimer, which is more than 3 fibrinogen extraction units, okay, for them, enoxaparin, which is probably to be described in therapeutic dosages, that is BID dosages. And for patients who are having less than 0.03 of fibrinogen extraction unit, they are to be prescribed in a prophylactic dose, that is an OD dose of an enoxaparin. Okay. Now, for patients for which you need to be aware that these patients can go into cardiac complications are patients who are having worsening lymphopenia, patients who are having elevated levels of ferritin, D dimer, patients who are having elevated levels of CRP, elevated levels of LDH. Probably these are the patients you need to be more aware that these patients can go into cardiac complications, and maybe you need to do serial monitoring of the troponin, serial monitoring. Probably they might require serial monitoring of their LV functions also. So this is about the acute management of such patients. Okay. Second thing I wanted to talk about is about patients who present with acute coronary syndromes. Okay, so patients who have come with acute coronary syndromes, especially ST elevation myocardial infarction and non-ST elevation myocardial infarction. ST elevation myocardial infarction, according to the guidelines, your door to needle time or door to balloon time should be 30 minutes and 60 minutes respectively, and your total time should be around 120 minutes, the total ischemic time. But in view of this COVID pandemic and due to the inherent delay, a 60-minute extra interval has been given so that the diagnosis of COVID could be established. So that 30-minute time can be extended to 90 minutes, and that 60-minute time of door to balloon can be extended to 120 minutes, and the overall time could be extended to 3 hours, that is 180 minutes. So if a patient comes to our hospital, and if we don't have a facility which could give him cardiovascular revascularization in a span of 3 hours, then I have to, and fibrinolysis is available, then I have to fibrinolyze the patient. Otherwise, and then after that, I have to refer the patient. If I can do that procedure in less than 3 hours, which is probably 2 hours in a non-COVID, which was there in non-COVID times, that is extra 1 hour time has been given so that you diagnose this COVID patients and treat them well. So that is the thing in which I want you all to be made aware. Non-ST elevation patients, obviously non-ST elevation patient, what is different between patients who are COVID and who are non-COVID? Majority of the times, patients who are young and who do not have the existing cardiovascular diseases, we have seen that their angiogram turns out to be absolutely normal, despite having ECG changes, despite having echocardiogram changes. For ST elevation MI patients, it's a mixed bag. Sometimes we have seen patients who were referred from us from outside with fibrinolysis and their angiograms were absolutely normal. We had patients, acute presentation patients, they had complete or total thrombotic occlusions of the arteries with absolutely normal other coronary arteries. Once you suck out the thrombus, it's absolutely the arteries are very clean. What about the post-COVID scenario? Now, post-COVID scenario, especially patients who are high risk for thromboembolism or high risk for arterial vascular events, you need to prescribe them at least 2 weeks of anticoagulation. You can give either Epixaban or you can give that's a second recommendation whether you can give Rivaroxaban or not. Okay, but at least I feel that at least 2 weeks of anticoagulation need to be given in this patient, because what I have seen here in our hospital that patients who are about to be discharged, their anticoagulation which is just being stopped, and in the evening when they're about to discharge, they come with a vascular event that they had an MI, they have a stroke, or they have a pulmonary embolism, something like that. So probably you need to be well aware of such patients. So even if the patient is discharged post-COVID, maybe in the next 2 to 3 weeks, you can expect this kind of thing. So you need to be anticoagulating these patients for at least 2 to 3 weeks. What about long-term complications? What I have seen here is that most of the patients who have systolic dysfunction, who have acute coronary syndromes, they have usually, if you manage them well, you give them standard heart failure therapies, usually they recover very well in the next 3 months or so. What about myocarditis leading to congestive heart failure and all? What about their post-COVID? What about and how to look out for them? Maybe you need to do, once you have treated them for heart failure management and all, you need to do serial echocardiograms for them to see how it evolves and all. But majority of the patients, if you follow them serially, what we have been doing in the last 3 months or so, patients who had come to us in March, April, or May when the pandemic started, usually their heart functions recovered to be normal. There have been some studies which have shown that post-COVID, these patients on MRI basis has seen late gadolinium enhancement, which is suggestive of myocardial fibrosis, and some amount of myocardial edema is also there, which is most located in the basal infrarseptal segments and all, and the mid myocardial segments. But as such, we haven't done any MRI here in our hospital. but overall functioning wise, they have recovered very well. So mostly, what about the sequelae of this COVID complication of with cardiac involvement, which is to be seen in the late stages, maybe time will tell. But yes, acutely majority of the patients who suffer from cardiac invalidation, cardiac complication, if they are given standard medical therapy, ST elevation, non-ST elevation, myocardial infarction, myocarditis, they all recover very well. Back to
Thank
Sitesh.
you, Dr. Irfan. Thank you. I think the message very clearly coming across from all the consultants is that have a level of suspicion, do serial evaluations both in hospital and after discharge, and don't take this lightly if someone has been sick enough to require an admission. Uh, just because their test came negative and they recovered and they went, that doesn't mean that they are out of the woods. The risk, as I have also seen in my uh, research work and evaluation, up to 4 to 6 weeks after this infection, a person really needs to be extra cautious, would be the right word, and so do their physicians, because a lot can happen in that time and beyond that also. Dr. Pathak, coming back to you, what I would like to ask you, sorry, Dr. Nadkarni, coming back to you, I'm sorry. What I would like to ask you is, if we are seeing, we keep talking about people having, and I certainly have seen my share of some known people who were perfectly well adjusted human beings who during a COVID infection primarily presented with panic anxiety attacks. And subsequently, after a lot of other investigations being negative, someone thought that this might be a COVID presentation, or they had some symptoms that led them up, maybe a low-grade fever or something, and turns out it was a COVID infection causing it. So, in your opinion, are we seeing a lot of acute psychiatric problems related to COVID infection? And also in the post-COVID phase, are there certain things that psychiatrists are dealing with that would be helpful for us consultant physicians also to look out for, and maybe refer cases to you all for their mental health problems?
First of all, what is very important is that we have been getting for last 7-8 months the COVID phobia cases,
Yes.
which means that they never had a COVID infection, okay, but they had intense fear of getting one, and they went through the COVID testing almost compulsively. And that is something that is very interesting, that there is something called COVID phobia, which is already there on the mental health horizons. So what is very important is, it's very interesting to understand how human beings react and how human beings respond to different situations, internal and external. And do you see that reaction and response, these are two very different things, not only behaviorally or psychologically, but also neuroscientifically. Reaction is more limbic system, response is more cortex. So cortical response is more thought over, but limbic system reaction is the first to come, and it is going to come because it is very impulsive. So whether you get infection or not, we all are seeing a lot of COVID phobia cases. That's point number one. Point number two, as you very rightly said, and also one of our colleagues said, that there has been a decompensation. I mean, something which was there, but because of the added trigger, people were just compensated in terms of anxiety and depression, have been pushed towards it. So that is something which was latent has been come up. Second point. Third point, especially in the group, a very important group of people who are having obsessive compulsive disorder. There, see, we all, the globe is washing hands. The globe is talking about not touching things. And many of our people who are suffering from OCD had exacerbations. And some people who had obsessive compulsive personalities have crossed the line and have gone towards OCD. Very interestingly. The fourth part is the post-traumatic part. The person getting a very complicated COVID episode or a very dear and near succumbing to COVID, causing trauma. Kids have lost parents. And although we say that mortality is more in the elderly age group, there have been certain cases of mortality in very young age group. And that has left, the survivors, the family members with the element of PTSD. Add to all this the psychosocial dimensions of the COVID times. I have taken a workshop for HR professionals of a company that was going to terminate the services of 250 of their employees. And why was my workshop with the HR professionals? How to communicate this negative news to the employees. So psychosocial complications add to this, which are going to emerge as anxiety, depression in the coming times. So on one side, you see a direct impact of the epidemic, the COVID part of it, and then you see the impact of the COVID times. I'm getting parents who are very worried about their kids about screen obsession, because now even the educational process is on screen. So screen has become indispensable. So whether it is recreation, whether it is socialization, or whether it is knowledge imparting, you are turning on to screen, as all of us are turning towards the screen just now to attend this webinar. So a time of discrimination has come. The point that I want to make from the mental health perspective is this: time for discrimination. Discrimination about what? How we are going to use the screen, how we are going to use our productivity, how we are going to have alternatives to cope up with the situation. And as you are aware that we are going to face a very fluid situation for at least 2 years to come. So we will have to go through an emotional turmoil. I'll share with you how post-traumatic guilt and depressions have come. One of the people I knew, that person's brother was admitted with acute COVID and passed away. And this person had a grief of losing a brother, okay? But to perform the last rites, this person went, a lady, with her husband to perform the last rites, okay? Flouting all the norms. They also did, they went to the police station, they did everything that had to be done, went to the cremation ground, came back, and within 10 days, both became positive. And this lady lost her husband. So now look at the grief, the trauma, that I've lost my brother, I've lost my husband, and taking the onus of that emotional guilt onto her own self. Look at the PTSD component. So the human stories, the human tragedies are also coming up very starkly, and they are going to be starker in future. So we'll have to discriminate between the stories of effective coping on one side. People have been innovative. People have been working wonderfully well during these circumstances. And then there comes a very important point. And that point is that nobody is infallible. All of us will have distress. We will have to empathize with each other. And in our age-old Bhagavad Gita, the roles of Arjuna and Shri Krishna were fixed. In these turbulent times, all of us will have to shift between being Arjuna and being Shri Krishna. We'll have to counsel each other. Today, Sitesh, I will be telling you something. You will be under distress. And next week I will be under distress and you will be my Shri Krishna. This is very important to learn as a society, that all of us will need each other. I will need a physician. Physician will need a mental health expert. We will need all relationships. Let's understand the value of everything. Let's understand the value of life. Let's understand the value of having a goal. Let's understand the value of having people around us. If we do that, then we will emerge as a stronger civilization. I'm again not using the word society. I'm using the word civilization because the challenge is global. And it's a point that we are facing as a civilization. That is something that we need to understand. Sitesh.
Completely agree. Very well said, Dr. Nadkarni. I think it's such an important time for all of us to be there for each other. Today we are not focusing on physicians per se, but I think that an entire seminar could be taken just about what physicians are going through mental health wise and the kind of help, support that they need, each one of us in whatever we are doing. And we are faced with these risks every day, and we sometimes take it back to our families, and again the associated guilt, fear. And I certainly have had a patient who just from washing his cell phone 10 times a day with sanitizer has gone through 5 cell phones in the last 8 months because he spoiled the screen every time, and he was not an OCD person before.
Yeah.
So and I had husbands who won't touch their wives and their wives who won't touch their husbands. So I think we are not even talking about relationships here at this point of time, but these are very important topics, I think, that people need to realize and recognize. And as you said, we have to come out stronger and be more careful about our responses rather than our reactions. And I think that's very, very important point. Dr. Phatak, I know that you may have to leave us in a little bit because you have another webinar that you have committed and you delayed it to be with us today. So a question that I would like to ask you is, do you feel that from whatever experience you've had, your colleagues have had, do you feel that the use of antiviral medications during a COVID infection, especially whether it be mild, moderate or severe, has any impact on the hyperglycemia or the sugar metabolism? And do you feel that post-COVID also, depending on when the patient sought medical care and when they took treatment, whether the use of antiviral agents such as favipiravir or remdesivir makes a difference to these cases? And from whatever the literature says or your experience says, we would love to hear from you.
Yes, Sitesh. As far as the efficacy of antivirals in diabetics, I have no doubt that they are good drugs. Favipiravir has some data and remdesivir has a stronger data. And in clinical practice in real world, we have found that in diabetic patients, they work equally well compared to non-diabetic. So I have no reason to believe that remdesivir works less in diabetic patients. It works as well as in non-diabetics. If you talk about their effect on the glycemic control, I have not come across any worsening of glycemic control with remdesivir or favipiravir. They may have effect, especially favipiravir has effect on uric acid and sometimes on liver function test, but not on the glycemic control. Yes, some interesting findings we have from vitamin C. Of course, steroids obviously worsen the hyperglycemia or may precipitate new onset diabetes. But vitamin C, which is given in high dose, we have come across some cases that even in absence of steroids, we have seen severe hyperglycemias. At present, I am not aware whether there are any studies that have shown that vitamin C worsens glycemic control. Some studies actually show that they improve the glycemic control because of their antioxidant effect. But from antiviral point of view, none of these drugs have negative impact on the diabetic patients from blood sugar levels or from any other metabolic parameters except transient uric acid elevation with favipiravir.
Thank you very much, Dr. Pathak. And do you believe that initiating, so, do you think that if cases came earlier to physicians and got on antiviral drugs, do you think that because we can assume that that would reduce the stress that is there on the system metabolically, that it may potentially reduce the risk of having complications or worsening diabetes or those kind of things? Or this is still too early to say because there's not much data comparing patients who got early treatment versus those who got delayed treatment?
Yes, it's a very appropriate and very good question, because antiviral drugs, if not started in time, have no value. They have to be started at least within first 1 week. Not that they will not work after that, but if started within first 1 week, favipiravir within first 3 days and remdesivir maybe in the first week, obviously they have given us very good results. Rather than waiting for hospitalization or the beds availability and then subsequent hypoxia and all that, where you will require steroids also, if you start remdesivir in timely fashion, probably the worsening of the illness can be greatly restricted. So the need for the steroids can be minimized, and obviously it will have a positive impact on the blood sugar levels as well as the overall diabetic status. So timely antiviral therapy is the need of the hour, and that would definitely prevent the worsening of the glycemic control, because you will be able to avoid the steroid therapy. Obviously, the infection burden will also be less, stress will be less, hospitalization need also will be less. So indirectly also it will have positive impact on the glycemic control.
Great. Thank you very much, Dr. Pathak. I know
so with your permission, I may have to leave now. And it was a very, very interactive session. I will be missing the concluding part of this. Thank you, Dr. Sitesh. Thank you, Urman Dhruv and Dr. Nadkarni. And thank you.
Thank you.
Dr. Dhruv, coming back to you, I would like to ask your opinion now with regards to, I know you've been very actively treating patients during their acute and post-COVID stages. What has your experience been with the use of antiviral drugs and the treatment of COVID, as well as the incidence of post-COVID complications? If you can shed some light on your experience with that before we start taking the audience questions. We have quite a few pouring in.
When SANJEEV is there, I would like to add a couple of things about diabetes. Yeah, we agree that favipiravir, one should remember a connection with ripaginide, and therefore one should not utilize. We have seen a couple of patients being given ripaginide because it works well on postprandial hyperglycemia, which develops during hospitalization when the patient is on steroids. So one should always remember those two drugs are not to be utilized simultaneously because it potentiates the effect of ripaginide. That's number one. Number two, whenever the patient is on steroids, it is generally the postprandial hyperglycemia, which is very, very high rather than fasting. And therefore, bolus insulin may lead you into trouble. So you should use a short-acting insulin. And number three, what we have seen a lot during now last 1 month, that those patients who develop diabetes or hyperglycemia during hospitalization because of steroids and who were prescribed thrice a day short-acting insulin and the long-acting insulin to control the sugars genuinely, after a week or so, they start developing for all family physicians and physicians to understand that you require to cut down the levels of insulin very rapidly once the steroids are off, because then they develop fasting hypoglycemia. And within last 1 week, we have seen about 6 to 7 patients who developed hypoglycemia because they were on 3 doses of short-acting insulin and long-acting insulin at bedtime. So this is, we must remember, as far as post-COVID complications are concerned, where you require to cut down the doses of at least Lentus or the basal insulin that is going on, because the moment the steroids are tapered, there is a early morning hypoglycemia and the patients come with 60 or 40 sugars in the morning. So that's about it. Coming to the use of antiviral drugs, well, we have been a huge advocacy. We have got advocacy of very early use of antiviral drugs. And fortunately, recently a trial of remdesivir has come out with a recommendation that antiviral use, even remdesivir, when used early, is very useful. So at least in Ahmedabad, most of the physicians are using antiviral drugs very early, and we can safely say there are very limited conversion of ward patient to ICU, at least in most of the corporates in Ahmedabad, is probably because of three reasons. Very early use of favipiravir just on day 1 or day 2. Very early use of remdesivir, as Sanjeev rightly pointed out, on day 2 or day 3, or as soon as before hypoxia develops. And a very judicious use of steroids. Never before day 5 and between 5th and 7th day if the indications are there. And of course, the use of oral anticoagulants. These four things have, at least I can boast about it, that has completely changed the scenario, at least in Gujarat, especially in Ahmedabad corporate, where the conversion or shifting the patient from COVID ward to ICU has gone down drastically, very drastically. And if we look at our own data, which we are collecting, we have got 3 physicians running OPD at our hospital, at CG hospitals. Very limited number of admissions, and the shifting of patients, COVID ward patient to ICU within last month is practically zero. When we look at a huge number of patients, about 400 or so within last 1 month. So use of antiviral drugs very early, as early as possible. And as was rightly pointed out in last webinar also, if a patient is positive and his relatives in the same flat or a same residence starts developing symptoms, even before COVID positivity, you can start antiviral drugs. Of course, the prophylactic use of favipiravir is going on, but I would strongly suggest, just like influenza, which we have been now advocating, use of antiviral favipiravir as early as possible on day 1 or 2 would probably change the scenario all over India. And we have seen something which is being told to us in May or June, where we had a huge mortality in Italy, lots of myocarditis and cardiac deaths and sudden cardiac deaths, and lots of patients developing MI and huge number of mortality. We have not seen anything, at least touch wood, in India. Everybody would agree to it that we have not seen it. Even the pulmonary fibrosis, yeah, we have seen amongst all 3 of us only 7 patients out of 1,000 that have been treated. So probably the less number of complications, less mortality, less sudden cardiac deaths may be attributed to 4 things that I said: early use of favipiravir, very early use of favipiravir, early use of remdesivir, very judicious use of steroids, not very early. Probably those things are helping. Back to you.
Great. Dr. Dhruv, just one question, because I do find, repeatedly it has been mentioned that people are overusing steroids. They are using higher than required doses of steroids, and they are also using it for longer periods than are needed. So can you give an idea of what kind of range of oral steroids or steroid dosages you all are using, just for the benefit of the audience?
Yeah, certainly. And to add to it, we have got few of the patients whose relatives are NRIs or at US, and most of them call back on day 1 that you have been diagnosed, start dexamethasone immediately. And probably, I believe that that is probably the reason of higher incidences of complication in US, because they are starting steroids on day 1. Of course, they are following their the WHO guidelines. But to me, steroids, we are generally starting the indications for steroids is on 5th or 7th day, when the inflammatory parameters continue to rise despite antiviral drugs. Patient continues to have fever more than 100 degrees despite antiviral drugs. A very low lymphocyte count below 1,000 at the end of 5 days or 7th day. CRP going on, D-dimer going on despite antiviral drugs, and fever. These are three important parameters where we start steroids on day 5 or day 7. The dose we are using is obviously methylprednisolone, but you can use dexamethasone. Generally, we used in the doses of 0.4 to 0.6 milligram per kg body weight. My colleagues use in twice a day doses, but I use it in once a day doses, 32 milligram of Medrol or 48 milligram of Medrol to start with, to be tapered every third day as CRP goes down. If CRP does not show the downward trend, then we continue it for 5 days and then we start tapering, but never more than 15 days. So every third day we taper it down and stop it maximum by 15 days. That's what we do, unless hypoxia develops, CRP or inflammatory markers continues to rise, or fever persists, in which case we start finding out the other causes of fever like UTI or some other secondary infection. But generally, 9 to 15 days is the time when we generally stop the steroids.
Thank you very much, Dhruv. And as an immunologist, that is also our approach, where if we can use steroids between 7 to 14 days, we also do the least amount of damage to the HPA axis, which leaves these patients at increased risk for other stress-induced complications if they have to stay in the hospital or go through any other illness in the subsequent days. So I think that's a very important message for the audiences. Coming to you, Dr. Khan, one of the last questions before we start taking audience questions. Have you all been, as cardiologists, been exposed to using antiviral drugs, and do you feel that the use of antiviral drugs are helping either ameliorate or prevent some of the cardiac complications that you all are seeing? And do you feel that there is some benefit, and what does, if not your personal experience, the cardiology literature say about the use of antiviral agents and the cardiac complications of COVID-19?
COVID-19, see, I think I have already discussed what about the spectrum of the illnesses. See, first you have the acute coronary syndromes, okay, which are presenting with, so you have non-ST elevation MI, ST elevation MI. So you have to give standard medical care of therapy to them. What about myocarditis and systolic dysfunction, which is seen in such patients? And whether obviously antiviral, that is remdesivir and favipiravir, is helping such patients? Mostly these patients who are admitted with and who have such kind of troponin elevations and have systolic dysfunction, they are primarily treated with remdesivir. Favipiravir, I think we have, I don't have any significant experience as such with favipiravir. So we are treating primarily with remdesivir. I think in my previous question, I had told you that in those patients, when we monitor serially the troponin I, and also the literature also shows that you have troponin I elevations till the day 4, and then it starts falling. And probably in patients who are complicated and who are non-survivors or who experience prolonged morbidity and mortality, the troponin I elevations keep on rising. So remdesivir probably because there is no head-to-head comparison which we can give about such patients. We have seen that remdesivir has probably led to the downfall of troponin I, probably which we see in normal patients from day 4, and which we don't see in non-survivors, has probably led to this downfall. And we have seen these patients who have got asymptomatic troponin I elevations, which is more than 5 times the upper limit of normal. We have also seen in patients who have troponin I elevations very severe in thousands and who have systolic dysfunctions. Also, definitely antiviral agents have helped these patients. But yes, whether remdesivir or favipiravir, I don't have any experience. Remdesivir, yes, remdesivir is helpful. Antiviral agents are helpful in patients who are suffering from cardiac complications due to the COVID-19 virus.
Great, perfect. Dr. Dhruv, you want to say something? You want to add something, please?
No, I don't want to add. But before we go into questions, I want to ask a question to Dr. Irfan. That do you believe that the manner in which India has managed, especially in Maharashtra, we have managed COVID, the complications, cardiac complications that we were talking in May, especially by European countries, have not been seen by India, especially in Maharashtra. Do you agree about it? Incidence, quantitatively.
The incidence of cardiac complications, if in patients.
Not as what were described when COVID came to our country.
See, basically, what I feel is that we haven't tested our patients so well, okay? Because when we started it, we were not giving even troponin I. We had patients who were mildly ill or moderately ill. We were avoiding troponin I. We had a minor package. I think in our hospital, we treated around 2,000, 3,000 patients with COVID. And we had a major package for patients who were elderly and who were hypertensive and diabetic and we did troponin in them. Probably we did not test in them well, and we had seen so many patients who had got troponin I elevations which were 5 times the upper limit of normal, but without any systolic dysfunction, without congestive heart failure, so without any other evidences which showed that. So yes, there is involvement
No. My question is not laboratory parameters. My question is cardiac damage.
So cardiac
damage to the
heart.
heart.
So it's a cardiac damage means, see, how do you assess cardiac damage? Cardiac damage you assess by biomarkers. Cardiac damage you assess by echocardiogram. Okay. So
that's what I'm saying.
So we have seen that patients who were having a troponin I elevations which were more than 5 times upper limit of normal, and they were treated with remdesivir and they got discharged with a normal 2D echo. Even with yes. So it is not that we were just seeing we might be having lesser intelligence probably of a different genetic profile, but yes, I would like to differ with that maybe we are seeing with less or more. We might I am not the right person. Maybe we might need to do a study and probably comparative kind of a thing. But yes, it has been very significant. Before we were not doing it, and after maybe June we started doing it more regularly. Then we started seeing more kind of troponin elevations. Even in our hospital, we had a discussion about this, whether we need to include troponin I in our routine evaluation, because ESC and ACC did not mention it not to do it. They told us that only if the patient has ECG changes, patient has got very high risk factors, then only you do it. But yes, after June, we started doing it very regularly and we started seeing a lot of troponin I elevations, which were probably asymptomatic kind of troponin elevation, but still they were quite high.
All right, great, perfect. So I think we are just, Manohar, the questions are not showing up in my chat box for some reason. If you can take a screenshot and send me, that would be perfect. I do have some questions that came in a little bit earlier and I saw them as they were appearing on the screen. So one of the questions was, we've spoken about antiviral agents, we've spoken about use of steroids, we've spoken about the need for, anti-inflammatory therapies. Are any of you all still using, I may say, hydroxychloroquine, ivermectin, or doxycycline in your therapies in these patients? Because I think that there are a lot of people who still go by the guidelines or the recommendations that are out there. So any of you all who would like to take some queries or respond to this? Yes, Dr. Dhruv.
Yeah, we as a protocol, we are using doxycycline twice a day for 5 days, ivermectin for 3 days, and favipiravir, all three together in all OPD patients as a rule. Especially after the UP report of a very nice response of the clinical trial suggesting a very nice response of doxy plus ivermectin, not Bangladesh trial, but even from UP we had a very good result of about 1,200 patients. So after that we are using all three antiviral on OPD basis, not after hospitalization.
Do you feel it's required to do all three? Could we not just do an antiviral agent and reduce the drug burden on the patient per se, if we may say it that way? Or do you feel that, so compared to before the UP trial, if you were using only favipiravir before with supportive agents that some people might use, vitamins and minerals and all those things, we won't get into that, but do you feel that using ivermectin and doxycycline has in any way changed the degree of results that you're getting compared to using favipiravir alone?
We are analyzing our data just now and will be coming out with the data. But personally, all three of us strongly believe that reducing viral load in the first 5 or 7 days by any means, whatever is available at present, should be utilized. Number one. Number two, we have been using evidence-based medicines for years together from the textbook and from the evidence is created all over the world. This is probably for the first time that India will be leading with the experience which would come out with evidence in next 3 months. So personally, we believe, yes, it is not at present evidence-based medicine. We do not ask everybody to follow it, but we are coming out with the data, and the initial results show that using all three together have reduced the number of hospitalization to a great extent.
Okay. There is a question with regards to the use of anticoagulants. Which oral anticoagulants do you all prefer to use? And what are the kind of dosages? I think Dr. Irfan, you may want to take this, and also you've already mentioned it needs to be continued for at least 2 weeks beyond, but the duration of the anticoagulant is what was being asked.
So duration of anticoagulation, we need to see basically for patients, all patients who are admitted with, I'm talking to you about ESC guidelines.
Okay.
So ESC guidelines say that all patients who are admitted with COVID-19, you see whether they are at a high risk for thromboembolism or whether they are at low risk for thromboembolism. If they are at a high risk for thromboembolism, then you till they are there in the hospital, and if they are admitted in the ICU, you need to give them unfractionated heparin and monitor their activated thromboplastin time. Okay, if they are not there in the ICU, you need to give them therapeutic dosages of anticoagulation. If they are at low risk of thromboembolism, you need to measure the D dimer, and if the D dimer is more than 5, then you need to give 5 fibrinogen extraction units, which is what they mention is that, then you need to give them therapeutic dosages of anticoagulation, that is enoxaparin 40 milligram twice a day. If it is less than between 0.3 and 3 to 5, then probably you need, even if you give a prophylactic dose of anticoagulation, that is enoxaparin 40 milligram once a day, that is sufficient. Now this is what the ESC says. Now what about suppose the patients patients are not there in the ICU, what about whether we can give novel oral anticoagulants like the apixaban, the rivaroxaban, whether we can give it to them. So Mount Sinai Hospital, you might be knowing, they also devised an algorithm for such patients. And they also mentioned it that all patients who have got moderate to severe COVID-19 infections and who have got admitted to the hospital, so if they are there in the ICU, you give them enoxaparin, that is therapeutic dose, or you can give them as an alternative. If they are not there in the ICU and they are at high risk for you can give them apixaban 2.5 to 5 milligram twice a day. Okay, or they have not mentioned it whether you can give rivaroxaban or dabigatran as an alternative to apixaban, but they've just mentioned it that you can give rivaroxaban as an alternative to apixaban. So the first choices they have mentioned is basically apixaban, which is 2.5 to 5 milligram twice a day, and enoxaparin. Duration of anticoagulation is just especially 2 weeks post discharge. You have to give anticoagulation for such patients, especially with moderate to severe COVID-19 infection.
And how important is it to monitor PT-INR and those kind of things in these patients? That's
enoxaparin. If you say enoxaparin usually does not require any monitoring, but if you have issues, then you need to monitor factor 10A in such patients. Okay, for patients who are on heparin, who are there in the hospital and who are at high risk for bleeding and probably who have creatinine clearance less than 30, and probably you are worried that if you give enoxaparin, then maybe a prolonged dosage and patient might bleed. So then you need to maintain an activated partial thromboplastin time. This is what you measure. And you need to maintain it between maybe 2 to 2.5 times the control value, maybe between 60 to 85 seconds or so. Probably if you maintain that, your patient is relatively safe.
Okay. All right. Great. The next question that we have, I think, Dr. Dhruv, you might want to take this. Dr. Shah asks, what is the treatment for post-COVID dyspnea and weakness?
So as we have told you, we should follow a protocol and trying to find out the cause for the same. One cause could be the inappropriate way of rehabilitation. So patient might have started doing a lot of work from the day one, which might lead to dyspnea. So graded exercise and training would solve most of the cases. Then you have to divide them between the psychogenic, cardiac and pulmonary. If it is pulmonary and if it is showing, the CT scan is showing fibrosis, breathlessness is worsening, the 6-minute walk test is worsening. In that case, in a very, very small number of cases, perfenadine may be utilized. But to me, this is never required if you ask the patient to undergo a very regular chest physiotherapy and rule out the cardiac cause is very, very important, and rule out the pulmonary embolism. So in most of the cases, you require a proper reassurance, graded exercise, chest physiotherapy, and probably a longer duration of anticoagulant if it is pulmonary embolism or right ventricular event, and a psychogenic reassurance. Otherwise, in a very small number of cases, perfenadine may be used, but that is a very, very small number. Pulmonary fibrosis at the end of 3 months is seen in a very limited number of cases, at least in our setup.
Okay, thank you. Dr. Nadkarni, I have a question for you. Do you feel that with the, even if we assume that of all the people who've had COVID-19, even 5% or 10% of them have some kind of mental health issues related to it. And we know that the numbers are higher because, like you said, it is not just the people who had COVID, but even the people who lived in the fear of COVID or in the consequences of COVID. This issue is there. Do you feel that the mental health fraternity is ready to face the onslaught of what is happening? Do you think that enough is being done in India for it? And also, do you feel that online counseling, which was something that mental health professionals always like to have the person in front of them so that they can talk to them, guide them, counsel them, do you feel that times are changing and things need to be different? So your thoughts on what should be done on a more general basis, and getting physicians more sensitized to get help, mental health help, which may not have been the case before. Your thoughts on that?
Thanks, Sitesh, for asking this question. Please understand that this is an opportunity for mental health. And as a number, numerically, we, the clinical psychiatrists, are very poorly placed. So almost 7,500 to 8,000 people for this vast population of more than 131 crores. It's a desperate situation to have. What is very important is that to get physicians, consultants, even general practitioners into the treatment of common mental disorders, this is the time to actually spread the network of even pharmacotherapy for CMDs. CMDs means common mental disorders, and include everybody who practices medicine into the net. And somebody has to take this initiative. A government, a pharma company, or the medical bodies, the different professional bodies across medicine, to have an online certified course of psychopharmacology for CMDs, common mental disorders. And anybody in the country does that course and starts treating common mental disorders, not taking it to psychiatrists. And actually, somebody like, our organization, we could be very, very proactive to provide even a module for that. So we need to take out mental health only from psychiatrists to every physician that is practicing in the country. That is the need of the hour, number one. Number two, how we can popularize mental health knowledge and information throughout the country. As far as we are concerned, at IPH, we have our own audio-visual channel. We have a YouTube channel called Avahan IPH, more than 75,000 subscribers. So something that would give continuous inflow and input of mental health information to common people. That is something which will have to be very important point in this context. And thirdly, I was listening to all the colleagues who participated in this seminar. See, look, We Indian clinicians are a very special breed. All of us who practice in this country. And what is that speciality? We blend evidence-based medicine with experiential-based medicine. That is the speciality of Indian clinicians. Many Western people would only go towards evidence-based. We are the people who integrate evidence with experience. And we do the jugaad very constructively. So we are the constructive jugaad physicians. And let's take appropriate pride in it. It is the constructive jugaad. I was listening to all three of our consultant participants, and I was thinking in my mind that, look, this is Indian physician, this is Indian consultant, the guy who does constructive jugaad, and that constructive jugaad has to be fortified, and that is something that we need to do and add that mental health dimension to it. So let psychopharmacology be common. The physicians, the other consultants, what do? At the most, they add an alprazolam or a clonazepam or sometimes a sertraline and very rarely a fluoxetine. Why? We give them just a 20 to 30 hour orientation and they become better psychiatrists. So why not take this challenge? Why not take treatment of mental health disorders to every practicing physician in the country, regardless of his or her specialty? Let diabeticians, let internal physicians, let chest physicians start treating anxieties and depression. There lies the answer, not in psychiatric referrals. Because what is very important is, Dr. Dhruva was talking about that breathlessness, some time back. That breathlessness that comes because of pulmonary fibrosis and breathlessness that comes because of anxiety. He made that wonderful reference. So the breathlessness, as a clinician, all our Indian clinicians know what is psychogenic and what is not. Let us give them a kind of a impetus and confidence. They will be very good psychiatrists. They will be mental health consultants, each one of them. And this is the time to do it nationally, I feel.
Very well said, Dr. Nadkarni. I think this is a very important point, and hopefully some people here will be inspired to take this forward and potentially, as you said, create modules. Certainly, as part of the last slide in my presentation that I moved very quickly through, I mentioned the importance of yoga, pranayam, meditation, which I think is so critical to mentally strengthen our country and something that India has given to the whole world. This is truly the opportunity to make that mainstream also in some way.
Just to
Yes.
add to it, Sitesh, since you mentioned that, it's very important to sensitize people from a modern medical perspective to look towards the traditional healing methodologies.
Absolutely.
In the coming times, what is going to happen is everybody is going to talk as a panacea about yoga, about vipassana, about meditation, not understanding it. It's very important, and I face it every day in my clinical practice, that how the modern science and the traditional healing methods have to be integrated. The
Correct.
whole medical fraternity needs to be sensitized about it. Otherwise, it would boomerang. I have
Yes.
seen that. I have seen people on the verge of a psychotic breakdown going on deep meditation and breaking down.
True. True.
So what is very
Guidance.
important
Very
is
important to have good guidance.
to sensitize our entire clinical population as to what is pranayam, what is yoga, what is meditation, what is vipassana, what is art of living, and how we can integrate it with the perspective of modern medicine. Unless we do that, the traditional wisdom and the modern clinical evidence-based medicine, everything has side effects.
True.
So that is something that this epidemic is going to tell us, and let's look at it and let's sensitize our medical population towards the use of all these things. Wonderful traditional methods, but how to use them with a wisdom.
Yes.
That is going to be a very important challenge, Sitesh.
Sure. Thank you. Dr. Mohammad Uzair asked, dose of COVID-19 vaccines in children. Dr. Uzair, COVID-19 vaccines are not approved for children at this point of time. Studies are going on, very much in place. Currently, it's mostly 18 and up. Some studies 12 and up, but largely children are excluded so far. It's mostly an adult-based vaccine, but it will be worked at soon. And studies are ongoing for pediatric dosing and pediatric frequency for the vaccination. Next question from Dr. Priyadarshi. He has asked about the fungal infections in COVID-19, especially in diabetic patients. I think that has been well covered by Dr. Pathak, and he has said some of the key points to look out for in these patients, and also looking at the face of the patient very carefully, and not just looking at their oxygen and their lab values, but looking at their face, their nose, their eyes, looking at black discoloration, looking at swelling that can come up during these illnesses, and identifying it early, and being quick enough to do a limited CT scan of the sinuses where you may actually pick it up, or calling upon our ENT colleagues to do a rhinolaryngoscopy and a rhinoscopy and identify these. Dr. Chatterjee asks, antiplatelet is a patient not using them, if a patient is not using them pre-COVID, in the post-COVID period as against NOAC. Antiplatelet agents, any role, Dr. Irfan, in the management of these cases? I know that there is mixed data coming out with aspirin now, and people are going back to using it again when initially they said it would be of no benefit. So any thoughts on that?
Basically, if this patient has got a moderate to severe COVID-19 infection, and he has got a high risk of thromboembolism, definitely these patients need to be given 15 days of anticoagulation for post-COVID by the time they are discharged. What about antiplatelet? Antiplatelets, if they have not been on antiplatelet, there is no point giving them antiplatelet if you have given them novel oral anticoagulant, that is NOAC. Okay. What about those patients who are on antiplatelet therapy and who also require a novel oral anticoagulant? Now, what you can do in such patients is that you can see how is their Has-Blood score. Has-Blood score is basically a score with which we determine what is the risk for bleeding for such patients. Okay, this is basically not something which is written in the books, but this is what we follow. And Has-Blood score is basically hypertension, age, stroke, bleeding, labile, INR, elderly, whether you are taking any concomitant drugs. If the score is more than 3, if the score is more than 3, I think you can give only NOACs for the next 15 days, and probably after NOACs you can add an aspirin to that. But yes, if the score is less than 3, you can give a single antiplatelet, and you can give a NOAC also. Why I'm trying to say is that yes, you can give only NOAC also, because we have seen in our hospital there were 5 to 6 stroke patients also who had come to our hospital, and strokes which were not thrombotic strokes, which were ischemic strokes, which were basically artery to artery kind of a stroke in COVID patients. So yes, you can give them as a single antiplatelet and a NOAC for the next 15 days post-COVID, and probably then after that you can continue with a single antiplatelet, that is aspirin.
Okay, great, thank you. Dr. Mahadev Desai asks, what are the percentages of these long-term complications that are being seen? Dr. Desai, the estimates from what we have seen range anywhere from 5%, depending on what problem you're seeing, to up to 20-25%. It's a very long list of post-COVID complications, but it is estimated that you can expect 1 in 5 people to have some problems, especially if they've been hospitalized, and maybe even 1 in 3 to have some complications if they've been hospitalized. And the longer the hospitalization, the more complex the hospitalization, more the need for the ICU admission, the higher the risk of post-COVID complications. Also, there is a message from Dr. Desai when he says that hydroxychloroquine may produce hypoglycemia. So this needs to be kept in mind for those who are using these kind of agents. Any comment, Dr. Dhruv, that you might want to make on that? I know we are not using hydroxychloroquine, but I guess some people still are.
Yeah. Hydroxychloroquine is basically utilized as an anti-hyperglycemic agent also. And at least those patients of rheumatoid arthritis who are already on hydroxychloroquine have been given steroids while in hospital for COVID. And if they have developed hyperglycemia and you are requiring anti-hyperglycemic agent, you have to be careful because HCQS itself is causing some amount of reduction in blood sugar. So the moment you taper down the steroids, you require to cut down the doses of anti-hyperglycemic drugs when the patient is on HCQS.
Thank you. A question again for Dr. Irfan. There have been cases of sudden deaths in COVID patients with normal D-dimer. Any thoughts on that, on why that would be happening? And, I know there are so many possibilities. We've discussed at least 4 different ways in which the cardiac involvement could be there. But any thoughts on sudden death in post-COVID patients with normal D-dimer values?
See, sudden normal D-dimer values, if you have a normal D-dimer, then you are excluding basically pulmonary embolism. Okay. And so the only possibility which remains especially when a sudden cardiac death is it an acute coronary syndrome? Okay. So if yes, the patient, that is why these patients need to be on anticoagulation post-COVID also for the next 2 weeks or so. And yes, you can have an acute coronary syndrome. You can have, subsequent to an acute coronary syndrome, you can have an arrhythmia like a VTAC or a VFib, and then you have a sudden cardiac death. Okay, within probably in 30 minutes, the patient is no more. That is what the definition of sudden cardiac death is. So yes, it can be seen, but you need to be giving these patients on novel oral anticoagulants. That is what I can tell. You have these patients, especially patients who are suffering from moderate to severe COVID-19 infection.
Great, thank you.
Can I add?
Yes, Dr. Dhruv.
Yeah. Most of the municipality and government health workers are using azithromycin, which HCQS people are taking. So there are lots of drugs which prolong QT interval, and we are seeing lots of deaths during first 2 months when people were taking this drug indiscriminately. So arrhythmias because of drugs must be considered, especially when you give favipiravir along with azithromycin and HCQS, that may lead to life-threatening arrhythmias.
Yeah. Actually, at present, we were not using only, we have stopped using, since remdesivir came up, we stopped using azithromycin and hydroxychloroquine and all.
No, but
so yes, probably.
Still provide only the 2 drugs.
Completely agree, but it's a point well made, because there are still physicians, and I'd certainly see prescriptions that they're still. So I think the message hasn't percolated further enough that now antivirals are the way to go, or as Dr. Dhruv mentioned, a combination
and
of antivirals.
Sitesh, add to it the domperidone that is going on, occasionally antifungal agents. Add to it again linear, that is levocetirizine. All these drugs combine to prolong the QT.
I think it's a very important point, because polypharmacy is a problem with some patients who have a lot of issues going on. Dr. Farah Ingley asks an interesting question. She says, what about the usage of monoclonal antibody? There is controversy for that too? Yes, there is controversy. We know that one monoclonal antibody trial has been stopped because it was not showing benefit. The others have gone forward. Eli Lilly's product baricitinib has been used and has a limited recommendation. I don't think these are available in India. Are you all aware if any of these are currently available here?
No, baricitinib is not available, but with remdesivir it has shown an excellent result of reducing hospitalization, but not morbidity or mortality.
Right. And then any personal opinions about convalescent plasma? I would like to take that as an immunologist. I would say that when convalescent plasma therapy was shown to be successful in the very initial stages in the Chinese studies, The most important fact was they were using the titer of neutralizing antibody, which was 1 to 320 or 1 to 640. And unfortunately here, that kind of titer evaluation is not done, and randomly if someone has just recovered from COVID-19 and their antibodies are positive on a test, they are taken as a plasma donor. And I believe that that has led to a lot of people getting disillusioned about convalescent plasma therapy. So I think the most important thing is knowing your donor, knowing the neutralizing antibody titer of your donor, and then using convalescent plasma. It can make a difference for very ill patients. But again, something that I would like, if any of the other panelists have thoughts on it, they can certainly share. I believe that done correctly, it is an invaluable therapy, but done, as I would say, empirically or randomly, it can not have much benefit and will actually not add much to the ultimate outcome of the case.
In critically ill patients where you are not sure whether it is cytokine storm or infection or persistent COVID activity or already damaged pulmonary epithelium, where you do not know, convalescent plasma is not going to be helpful. So convalescent plasma, or for that matter COVID immunoglobulins, if at all they are going to be helpful, they would be helpful in first week, as we are always talking about it, when it is not it is not feasible to give. So convalescent plasma in a very seriously critically ill patient is quite a late phenomenon.
And interestingly, that is when it was shown to be most beneficial in the Chinese studies, but they were using plasma that had very high titers of neutralizing antibodies. So I think that that's where the whole problem is coming in, is when it's used, how it is used, and whose plasma is being used. We have several people who have thanked us. This is for the panelists for a very excellent program, and we truly appreciate everyone who's still with us. We've completed 2 hours. We are just over 2 hours. I'll take this one last question because it is a very interesting question. It doesn't directly relate to any of us, but it brings up a point that we have known since time immemorial of what illnesses do to human beings. Dr. Abhijit Gupta says that hair-related issues, okay, are crowning glory. After COVID, he's had 2 women who have reported like bunches of hair coming off their head after COVID recovery. And what I would like to say to Dr. Abhijit Gupta is, Dr. Gupta, any stressful situation in a person's life, and I'm certainly, you're convinced after hearing Dr. Nadkarni and everyone else that COVID is as stressful as it gets, and getting it and going through all the recovery of it and how much it drains out of your system in terms of energy and nutrients. It is not surprising because we've known people after typhoid losing their hair and going bald. So I think that COVID-19 most certainly, with all the stress physically, biochemically, emotionally, psychologically, and in every other way that it causes, can lead to hair fall. If anyone else wants to add something to it, please go ahead.
Yeah, hair fall has been shown to be a very important feature, and personally I believe it is not only because of stress. Some pathophysiology would turn out or will come out later, but there's a huge number of patients complaining of hair fall only during the time of COVID. They are anxious, stressed for a long time. Ultimately, they develop COVID, and during the time of COVID or post-COVID 2 weeks, huge number of patients complaining of hair fall.
I did not want to lighten what was asked in the question, Dr. My point was, I certainly believe that there are a lot of micronutrients that are depleted from the human body during COVID-19 infection, and they do make a difference. I believe that there is a lot of gastric inflammation which also contributes to it. There are multiple factors which are physical and biochemical factors which can be corrected with the right treatment. So I do believe that optimizing vitamin D, vitamin E, utilizing zinc, selenium, which are so important for hair care, using biotin, there are multiple things that can be done to help these patients. And I think Dr. Nadkarni is very eager to add something to what we are saying. Please go ahead.
Just a couple of sentences since we are running out of time. But what is equally important is to look at all human beings in the wholeness of their existence. You know, what our modern medical perspective tells us is a kind of a reductionistic approach, and which is very important. I'm not undermining it at all. But the reductionistic approach, going towards a symptom and alleviating it, has to be also integrated with the holistic existence of the human being. And what is very important when you are dealing with a pandemic is, yes, focus on the symptom, but don't forget existence of humanness. It's the humanity, it's the human life, it's the humanness in the perspective of which all clinical conditions exist, all symptoms exist. And treat a symptom, but do not lose the holistic perspective. Thank you, Sitesh.
Thank you very much, Dr. Nadkarni. And I think with that, we will come to a close. We are about 10 minutes over our time. I really want to thank Dr. Dhruv, Dr. PATHAK, Dr. Nadkarni, and Dr. Irfan Khan for being with us this evening, for sharing all your expertise, insights, knowledge, which I'm truly believe that the audiences, our consultants across the country, our general physicians across the country have gained a lot from. I appreciate everyone's time. I thank Hetero Healthcare, who are really doing a fantastic job. This is my 8th webinar or 7th webinar. I can't remember now that I'm doing both as a speaker and a moderator. And they have certainly, by bringing first remdesivir and then favipiravir, both in the 200 milligram dose, and the first to introduce the 800 milligram dose also, which is so important. Someone actually asked among the question, what is the role of general practitioners in all of this? General practitioners can pick up COVID-19 cases at the earliest stage and begin antiviral therapy for them and make a difference to the ultimate outcome of this disease, I truly believe. And obviously with supportive, depending on the data, depending on your comfort level, there are use, as Dr. Dhruv has mentioned, of ivermectin, doxycycline, of using supportive vitamin E and other substances which can be of benefit and value, and optimizing them to get these patients well. So again, thanks very much to Hetero Healthcare, to Mr. Shastri, to Mr. Shailesh, to Manohar and the entire team. And you all have a very good night. Stay safe, stay blessed. Recognize that this too shall pass, and the human spirit is way stronger than any virus that is out there. And in unity lies our strength. And so as one, as Dr. Nadkarni so rightly said, changing roles as Krishna, Arjuna, and probably the entire Pandavas and the entire story as it goes. We can be Hanuman at times, we can be anything that's needed depending on the need of the hour, and then be there for others when required, and we can all get through this. Thank you so much. Have a blessed night. God bless us all. Take care. Thank you again.